So I'd like to discuss and begin this session on rectal displacement and what it means and where we're at with it. So we know grade 2 plus GI toxicities can certainly affect quality of life of patients. And the CTCA grade 2 is considered moderate with the various types of side effects, constipation, persistent symptoms of constipation requiring laxatives, diarrhea, 4 to 6 stools per day, hemorrhoids, symptomatic where banding or medical intervention is indicated, and then proctitis, which is rectal discomfort, passing blood or mucus, and then rectal hemorrhage. And overall, these rates with standard radiation are between 10 and 38% in the literature. So the goal of rectal space has always been to decrease some of these radiation-related toxicities, and they all have kind of a simple way of doing it, and that is putting something between the prostate and the rectum. So when you radiate the prostate with any form of external beam radiation or even seed implants, that space reduces the risk of damaging the rectum by basically creating this physical space. And here are just some particular slides and illustrations demonstrating that. This is one with using Barrigel, which we'll hear about today. But if you look at the bottom slides, you can just kind of see how that works. And basically these, for all of these things, you are basically inserting something between the fascia of the prostate, and Denevier's fascia, and the fascia of the rectum. So that's a very important factor, which you'll see, and if you see some of the demonstrations, that's the area that we need to target. Now, the risk of doing these things is that you do need to transperineally stick a needle and find that space, and that's where there is some skill involved in doing that. But once you find that space and you can get that in, there's no question you're going to push the prostate away from the rectum, and then no matter whatever form of radiation you're going to do, you're going to markedly reduce dose to the rectum, and I'm going to show you that in the next couple of slides. So interesting enough, one of the first studies published on this was from 2007, and this was looking at transperineal injection of hyaluronic acid in the anterior perirectal fat to decrease rectal toxicity from radiation using IMRT for prostate cancer. So hyaluronic acid is now, just so we kind of clarify, is now the product used in the Barrigel spacer. And I will be speaking mostly about hydrogel, which is polyethylene glycol, which is used in the SpaceOAR product. But again, I just took these pictures because they're some of the first pictures demonstrating. You can see a sagittal MR slice on the left. You have your symphysis pubis, you have your bladder in white, you have your prostate, and then you have your rectum. And then on the right, you see basically hyaluronic acid that's been injected into that space between the fascial planes. And right off the bat, you can just clearly see how by putting that material in, you're taking the prostate and moving it away from the rectum. And in that particular study, there was a difference in the mean rectal dose with and without hyaluronic acid on 27 patients for this particular study. And if you look just at the rectal mean, the Dmax dose is higher, 708 centigrade without hyaluronic acid and 500 centigrade with hyaluronic acid, significant p-values. So you can clearly see it with your eyes. You can understand it if you think of radiation as isodose lines around the prostate. You move it away from the rectum, you lower the rectal dose. Here's just another nice demonstration of kind of what this looks like, and we did hear a lot from Dr. Gorn about the transperineal approach, and certainly very fascinating, the anesthesia that he can give to numb the patient. So this is a procedure that can be done on that type of anesthesia. It could also be done with MAC or sedation or more deeper general anesthesia. But it is important because it's a very delicate space that the patient isn't flailing around or screaming in agony. So I highly recommend some form of anesthesia, and you really need to keep the patient from moving. And obviously, just by sticking a probe into a patient that's not anesthetized, they're going to be very uncomfortable and they're going to move around. This is a nice illustration showing the prostate, the hydrogel, and the rectal wall. And again, very simple to see. This hydrogel is just pushing the prostate away from the rectum, which will enable radiation to be delivered more efficiently and reducing rectal dose. So this is one of the early papers using the hydrogel spacer in men undergoing prostate cancer radiotherapy, 12-month toxicity and proctoscopy results of a prospective multi-center phase 2 trial. Ted DeWeese was the senior author on this. And again, looking at these nice diagrams, A is prior to or without using the hydrogel spacer, and picture B is showing the hydrogel spacer in place. And just clearly, if you look at that kind of turquoise line outlining the prostate, you can see that it's pushed away from the rectum. And if you look at the red being, let's say, the prescription dose, you can see we give a few millimeters posterior margin, but that margin touches the anterior rectal wall when you don't use the hydrogel spacer. But when you do use it, that red isodose line is falling in the spacer, but not touching the rectum. And this was a comparison of Vienna rectoscopy scores at 12 months for men treated with SpaceOAR versus a comparison to the literature. And the overall VRS score, you can see that there is just reduction in all the various grades or scores with the use of the SpaceOAR hydrogel spacer compared to the literature. If you look at telangiectasias formed at 12 months afterwards, you can see that there is a much lower telangiectasia formation rate with the use of SpaceOAR versus the literature. And again, the SpaceOAR are the red bars. You see that they're much lower. And it's these telangiectasias that are fragile. They break apart. They cause rectal bleeding that patients find very disturbing. And just looking at the mucosa, congested mucosa, again, much lower with the SpaceOAR product versus a comparison to the literature. So this was the first publication in 2013, a multi-institutional clinical trial, rectal reduction via injected polyethylene glycol or hydrogel during IMRT for prostate cancer. And again, Ted DeWeese is one of the senior authors in this trial. And again, if you look at before spacer, the image of the prostate and the rectum, they're touching each other. And what you can see is that kind of white material between the prostate and the rectum are the two fascial layers that are next to each other. And so when you stick this needle in to do it, and we'll go over that in the course, you want to get right into the middle of that space. So after external beam radiation, three months past putting in the SpaceOAR, you can see what it looks like in the second picture. And obviously, again, you can just clearly see how the prostate is pushed away from the rectum. And then this hydrogel spacer, typically, we think of it as lasting for 4 months. So at the end of the phase, you can see that gets absorbed by the body. So patients always ask, it's going to be in me forever. And you can basically tell them 4 months, and then it's kind of dissolving. And again, this just basically shows how you can reduce on what we call a DVH curve, the dose that's delivered to the rectum by using the spacer. And this is a further multi-centered hydrogel spacer prospective trial. It was a randomized controlled pivotal trial, dosimetric and clinical effects of perirectal spacer application in men undergoing prostate image-guided intensity modulated radiation therapy. So we're fortunate to have Dr. Sylvester as one of the authors here, and he's going to help demonstrating some of these products. So if you have questions about or because this is a landmark paper about this paper, he's here to answer those questions for you. But just if you look at the rectal DVH data, it's SpaceOAR pre, so the analysis done pre. A control group that did not get the spacer, and then the SpaceOAR, the analysis of the rectal DVH or dose delivered after the spacer is placed. You can clearly see the rectal DVH as the green line, which is after the spacer has been placed, and you look at any given dose parameter, it's much lower than not doing it at all or doing it or measuring it before the insertion of the spacer, which those two would be pretty much identical. And again, this is a comparison review of phase 3 clinical trials using hydrogel spacer and prostate radiotherapy. Neil Shore was the senior author here. And what you can see, if you just look at the table there in terms of the spacer arm and the control arm and just kind of compare those and look at the p-value, you have rectal pain markedly reduced, you have late GI and rectal toxicity markedly reduced, you have late grade 2 and rectal toxicity reduced. But what was interesting in this particular study, a couple of things that I found to be interesting, that there was decrease in the urinary quality of life, so which is one that wouldn't be quite obvious. And also potent men at baseline retaining erections was higher with the use of SpaceOAR than versus the control. So maybe John later on can comment on what the explanation for that is, but that's what was found in this trial. And so this is a paper that we published, which was the impact of the rectal hydrogel spacer on dosimetric and toxicity outcomes among patients undergoing a combination therapy of external beam radiation therapy and low dose rate brachytherapy. So we looked at 168 patients. 22 patients had received a rectal hydrogel spacer, among whom the mean separation between the rectum and the prostate using this was 7.5 millimeters. And the V100, which is the amount of rectum covered by the prescription dose, was reduced by 47% with the use of the spacer compared to those patients that did not receive it. And this is just an example of how we were using it. We were using it in combination, often with a combination of seed implant and external beam. Either we did the SpaceOAR up front, then might have done the external beam, and then the seed implant at the end. More recently, as I mentioned, we are now doing the seed implant up front and putting the SpaceOAR right at the end under the same anesthesia and following with external beam. But you can just see, and these patients have these seeds in place, which you can see that even when you put the SpaceOAR in afterwards, you are basically eliminating dose to the rectum from the seeds itself. So those doing seeds, when we first did it, when Neil and I first started doing this, there was no dose volume histogram analysis or any relationship between the dose to the rectum, and we wrote this paper probably close to 20 years ago showing that the dose comes off the prostate, the greater amount of tissue of the rectum that irradiates, the more likely you're going to have rectal bleeding. You can see just from here with the seed implant, by putting that's the black space there between the rectum and the prostate, you eliminate dose to the rectum. And I can tell you that I have not seen any rectal bleeding in any patient since I've been doing spacers. And that's, it's pretty impressive. So I just want to end on a couple of other papers that have come out. This is a prospective analysis of hydrogel spacer for patients undergoing radiotherapy, and the results that there were no postoperative complications. Mean prostate volume was 66, and rectal dose volume parameters were observed. And this is, basically showing what they found here. Again, just more diagrams showing you. And the reason I show so many of these diagrams, because this is the whole key to spacer. You don't really need to know physics or anything like that. Just the basic concept. Move the prostate away from the rectum, you're going to get less rectal dose. And you can just see the dose lines of the 78 gray in the patient without the spacer, pre-spacer injection, I should say. And you can see that it is basically the isodose lines touch the anterior rectal wall, but when you put a spacer in, that dose, the prescription dose, doesn't even touch the rectum. Here are just some of the differences pre and post in the dose volume histograms for the rectum, showing a reduction in the rectal dose. This was a paper by Michael Zalewski and the group at Memorial, placement of absorbable rectal hydrogel spacer in patients undergoing low dose rate brachy with palladium-103. This is showing some of the information. And essentially, same thing that you continue to find is that a reduction, in this case, in some GI toxicity, proctitis with the use of the SpaceOAR reduction in rectal bleeding. Just another picture of it. And so let me go back. So basically, what we have now, and this is the title of the talk, although, is that the SpaceOAR company has created a product called SpaceOAR Vue, which has contrast, and this has really been a game changer for evaluation of SpaceOAR placement. Because now that we have the Vue, prior to the Vue, it was very difficult to actually see the SpaceOAR when you do your treatment planning CAT scan because it was black, and you really needed an MRI to see the difference. But now with the SpaceOAR Vue, there's contrast there, so you can clearly see where there it is, and you can certainly clearly see if there's been infiltration of the prostate or infiltration of the rectum. Now, why does this make a difference? Because I've seen many cases from the outside where people basically identify the SpaceOAR and it is infiltrated in the rectum and they're not making that connection, maybe because they're not seeing it well. And so they're basically contouring it, and what they're contouring as SpaceOAR really still is rectum. And so they're not taking that into account. So it can happen that the SpaceOAR is placed in the rectal wall, and it can happen, it's been documented, in the prostate. But the key is to be able to recognize that and contour the structures properly. If you contour the structures properly, then you can still, with your physics, reduce the dose to the rectum. But if you say, oh, that's SpaceOAR, but in fact, it's in the middle of the rectum, and you don't take into account that tissue with the SpaceOAR is rectum, then you can overdose the prostate, overdose the rectum, and that's when you get into trouble. So the SpaceOAR Vue, here's a picture of it, I believe. This is just a picture of the setup, so it's essentially very similar to this, the original SpaceOAR, except the liquid looks like a little different color. The main difference is that it's a little bit more viscous, and it has to be inserted a little bit slower so that you don't get too widespread. Other than that, it's very, very similar. So going from one to the other is not a big deal, and in most cases, it's a benefit. So this is kind of what it looks like from an actual patient. So you can see, you can clearly delineate where the SpaceOAR is from the rectum and the prostate. And this is from a paper we're kind of looking at that. And you can see it makes a big difference if you're using it after a seed implant. So picture A shows it, and you can kind of see it, but because of all the artifact of the seeds, it's very difficult to really delineate. But if you look at B, where you're using the Vue, which has the contrast, you can clearly see where the SpaceOAR is, where the rectum is. So it really makes a big difference, I think. And again, I'm not pushing one version versus the other, but once you switch over, you're not going to really want to go back to the non-contrast version. Okay, so yeah, I just wanted to end on this particular slide. It brings up a couple of things, not just about spacers, but also about SBRT. So this was a multi-institutional phase 2 trial of high-dose SABR or SBRT for prostate cancer using rectal spacers. And so this Robert Timmerman in Texas was the author, and he's one of the people that wrote about the early experiences, but also wrote about a lot of toxicity with going to pretty high doses to the prostate. So there were 44 men enrolled in this trial. It also had Michael Zaleski from Memorial, and 43 were eligible for protocol analysis. The median follow-up for surviving patients was 48 months. And so this may be a little bit different, but what he did is Dr. Timmerman did his own rigid proctoscopy with a rigid scope to look for rectal ulcers, and he did that in all the trials that he's done. So whether we would see these high rates of rectal ulcers if we did that, I don't know. Whether they're all clinically important I'm not sure. But what he found in this study, now this is an interesting part going back to SBRT. He gave a dose, which I don't think anyone is giving, which is 900 centigrade of the prostate every other day, 5 fractions, a pretty high dose. And again, just to give you a reference point, RTOG, most of the trials were 725 centigrade given every other day. So this is a real significant jump. And in the study, though, they found that, again, there was, if you look at urinary grade 2 toxicity, it was pretty high. And I think, so no matter using the spacer or not, you're treating the prostate, you're treating it to that high dose. You're still going to get a lot of urinary symptoms. But what was interesting was that, and their conclusion was kind of interesting, was that their findings were that when they did this rigid proctoscopy, they found ulcerations in 14% of the patients, which they say is lower than their original trials not using using the SpaceOAR. But I think, to me, that's still an unacceptable ulceration rate, even if the patients aren't seeing it. And if you look at the grade 2 or more toxicity, rectal toxicity, it's about 25%. So to me, it's still too high. And I think it's not about the rectal spacer in this case. It's just, I'm putting it in because it's a lesson that, there is a point when if you deliver too much dose, you're going to cause too much toxicity.